So it's our pleasure to introduce our visiting speaker today, Dr. Daryl Gress, who comes to us from Charlottesville, Virginia, University of Virginia. Dr. Gress got his undergraduate training and medical school at Washington University in St. Louis. He then did an internship and I think just 1 year of medicine residency before seeing the light and joining neurology. He then went from Hopkins, where he did his medicine training, to Mass General, where he completed his neurology training, and also stayed on there for stroke and neurocritical care fellowships. He stayed on there for an additional year as an instructor, and then moved to UCSF, San Francisco, where he was an assistant and then associate professor of neurology. And in 2007, he moved to the University of Virginia, where he is now, where he's the director of the Neurocritical Care Unit. And he's going to be talking to us. His interests are in acute brain injury and brain trauma, subarachnoid hemorrhage, and he's going to be talking to us this morning about the consequences and management of subarachnoid hemorrhage. Dr. Gress?
Thank you, Dr. Greenfield. I certainly appreciate the opportunity to visit with you this morning about subarachnoid hemorrhage. It's a pleasure to be here, and I thank Dr. Greenfield for that opportunity. I'm going to be able to spend some time today getting to know some of you folks, and I look forward to that. I have not been to the University of Arkansas Medical Center before, so I have a lot to learn about things here. We're going to spend a few minutes this morning talking about subarachnoid hemorrhage, and it is one of my favorite disorders as a neurointensivist, and it causes a great deal of dysfunction in the brain. You can see how the brain becomes coated with blood, not the way it's meant to be. It's supposed to be coated in pristine cerebrospinal fluid. I usually liken cerebrospinal fluid to the champagne of body fluids. Subarachnoid hemorrhage is a complex and serious disease, and it is a challenge for the neurointensivist, but one that's my favorite because it has predictable complications. It has a timeline that one can come to understand. In each case, you need to develop a strategy ahead of time about what you're going to do with things, and you need a team approach to try to take care of all of these problems in an optimal fashion and we'll talk about those. Subarachnoid hemorrhage is not the most common kind of vascular disorder. In fact, compared to stroke, it pales in frequency. But I will say that because it tends to strike younger people and because it is such a serious problem, it accounts for about a fourth of all stroke-related years lost for people under the age of 65. So it has a disproportionate burden for younger people. These are approximate figures because no one really knows for sure. Subarachnoid hemorrhage is a bad thing, probably around a 50% acute mortality. And of those that survive, another 50% are going to have risks of serious disabilities. The prognosis, like many things, can be related to age, but clearly clinical status at presentation is one of the greatest predictors of outcome. Subarachnoid hemorrhage has multiple mechanisms. So for those of you who may be interested in board questions, if somebody asks you what's the most common cause of subarachnoid hemorrhage, the answer is trauma. Now, if someone says what's the most common cause of spontaneous subarachnoid hemorrhage, the answer is aneurysm. The others on the list are relatively less common in terms of other vascular malformations, etc. If we were at Sloan Kettering, we'd probably be more into bleeding dyscrasias. It's relatively uncommon in the general group. And then there's the angiogram negative, thought to be a special group, and that accounts for maybe 10 to 20% in various series. So of those angiogram negative, they are divided sort of into two groups. So that means that you've done an angiogram and can't find an aneurysm or vascular malformation. There's one group that are really the benign paramesencephalic hemorrhages. The Dutch Van Jan described this years ago, and it is a fairly unique syndrome with just a small amount of blood in the interpeduncular fossa and prepontine cisterns, and probably is truly non-aneurysmal. There are others that are angiogram negative that have huge amounts of blood that are probably not of the benign version. So this would be just a standard benign paramesencephalic subarachnoid hemorrhage and a fairly small amount of blood, and because of the small amount of blood, not really much for risk of sequelae, and it probably isn't aneurysmal, and the natural history of these is that they don't go on to have recurrent hemorrhages, etc. So it isn't just a case of missed detection of the aneurysm. These are probably bleeding from venous plexus on the surface of the brainstem and not a major problem. Aneurysms themselves tend to be fairly small, innocent-looking things, but can cause a great deal of problem. They tend to occur at branch points of vessels in the basal segments of the arteries around the base of the brain. You'll see that they're more common in middle cerebral bifurcation, carotid bifurcation, anterior communicating artery where it bifurcates between A1s and A2s. And it's important to recognize that they probably are truly acquired lesions. There are relatively few of these that are developmental, but they are acquired through life. Probably thought in part to be at stress points where there are abnormalities of elastin and components of the arterial wall, although I will say that we do not understand that piece very well. From a clinical perspective, subarachnoid hemorrhage is almost always associated with headache. I would have to say, in seeing many of these over many years, I can think of only one person I've seen who was awake who didn't have a bad headache after subarachnoid hemorrhage. There may well be a transient alteration in consciousness associated with the hemorrhage itself. Remember that the aneurysms at the base of the brain are in the subarachnoid space, so that when they bleed, there then becomes continuity between the intra-arterial contents and the subarachnoid space. That is to say, the pressure gradient then normalizes and the ICP spikes up, approximating mean arterial pressure, and that can cause a momentary dazed or stunned event or frank loss of consciousness, depending on the severity. So even if people don't pass out or become unconscious, there's often a transient alteration. And in fact, for many, if the hemorrhaging doesn't continue, which of course if it does, it will be a fatal event, so it stops, people can actually have quite normal neurologic exams, save for the headache following that. And it is a little bit sobering to recognize that in some of the studies, this was Stefan Mayer's survey of patients with subarachnoid hemorrhage in Columbia Hospital, that in retrospect, about a third of them had sought medical attention for headaches in the preceding day or two, with difficulty appreciating that that headache was subarachnoid hemorrhage. The clinical suspicion remains the number one piece of diagnosis, and then non-contrast head CT. There probably are a few that even if the CT scan is negative, lumbar puncture can be helpful. But if you get to that point where you believe that there's a hemorrhage and a headache that is suspicious and the CT is unremarkable and you're doing lumbar puncture, just remember that you are entering an endeavor that will be fraught with interpretation problems. You've got to then decide if there's blood in the CSF, was it some that was there already, or did it come from a traumatic lumbar puncture? And there are no perfect answers to separating those two. So I have seen more confusion, but at least I would say there are times where lumbar puncture still remains a necessary test to try to distinguish subarachnoid hemorrhage. I had hopes for MR and FLAIR images to improve that sensitivity, but it isn't as easy to accumulate the images or do the interpretation with the degree of experience. So it still is probably viewed as for interest more than for practical purposes for most of us. Subarachnoid hemorrhage often looks like this, with increased attenuation in the basal cisterns and the whiteness, but I'd put this in for the consult residents. Is this really subarachnoid hemorrhage? And of course, if I'm asking that, the proper answer to that question is no, of course not. And what is this then? This looks like subarachnoid hemorrhage, and I put it in for the consult residents because sometimes you'll get confused by this. This is really pseudo-subarachnoid hemorrhage, and I can prove that to you because there is mostly DWI abnormalities and no FLAIR sequence there at all. So that this is what happens often post cardiac arrest and post arrest, and you get congestion of venous structures at the base of the brain, and the whole brain attenuates radiation less. It becomes darker, and the venous spaces become whiter, and it's an illusion of subarachnoid hemorrhage. So it's really pseudo-subarachnoid hemorrhage. So I only point that out so that when you're doing consults, you don't get fooled into thinking that it was subarachnoid hemorrhage that caused the coma. That's really not subarachnoid hemorrhage. In the initial phases of this, I think the most important thing in the emergency room to do is to think about what one can do to help decrease risk of recurrent hemorrhage. And while there is no good answer to that in the emergency room, controlling blood pressure seems to be an accepted part of the early treatment, that is, decreasing pressure gradient across the wall of the aneurysm. And most of these patients are profoundly hypertensive at that time anyway, so it makes reasonable sense to try to control blood pressures, and one usually has to resort to intravenous medications. I'm fond of labetolol, nicardipine works as well, and trying to bring blood pressures down to something more reasonable, like systolic pressures in the 140s or something. There may be patients whose level of consciousness is already markedly depressed, and you have to think about whether you're going to need interventions like ventriculostomies. And clearly this is a neurocritical care process, and will need critical care management. There was a time when I started this business where everybody got loaded with phenytoin with subarachnoid hemorrhage in the emergency room. I think it's become clear that seizures are a relatively uncommon sequelae of subarachnoid hemorrhage, and that routine use of anticonvulsants is not necessary. If you're going to do it, I would argue for a fairly short course of something other than phenytoin, because there is in fact data to suggest that phenytoin use in this setting leads to worse outcome. There's a negative effect of phenytoin. Most of the events that are thought to be seizure in subarachnoid hemorrhage, either are a direct result of the hemorrhage or are not hemorrhage or not seizure in the first place, and may be more epistotonic posturing related to the high ICP. And so I think routine use of anticonvulsants really is unnecessary. The prognosis, as we said, is most related to clinical condition at presentation, and the Hunt and Hess score for subarachnoid hemorrhage prognostication goes back many years now, and is a clinical score that gives prognostic information for subarachnoid hemorrhage managed surgically. That's how the data was collected in a day when everything was taken care of surgically. And the scale goes from Hunt and Hess 1 to 4. So Hunt and Hess 1 patients have a subarachnoid hemorrhage but are absolutely asymptomatic. Hunt and Hess 2s have a severe headache but are neurologically normal on exam. 3s begin to have focal deficits, cranial nerve palsies, hemipareses. By the time you get to Hunt and Hess 4, there is impairment of mental status, and they're sleepy, stuporous, and Hunt and Hess 5s are frankly comatose. So that there's a big split between 1, 2, and 3, and 4 and 5 in terms of prognostic outcome. So there's the good grades, 1, 2, and 3, and the poor grades, 4 and 5s. And the majority of people will survive and do quite reasonably well with 1, 2s, and 3s. 4s and 5s are maybe about 30% survival and less than that of good outcome. But if you're thinking particularly about the 4s and 5s, neurologists can actually do a better job than just the Hunt and Hess score of depressed level of consciousness. Because the real question is, why do they look that way? So you will see here 3 CT scans of Hunt and Hess 4 and 5 patients. And I will make the case that the center individual has obtundation largely related to acute hydrocephalus. You see a little bit of blood in the posterior horn on the left, but most of that is just hydrocephalus. And about a third of patients will have developed acute hydrocephalus that's symptomatic by the time people get to the emergency room. The mechanisms of that we can talk about if folks are interested about how it can develop so fast. But the individual in the middle with ventriculostomy treatment may well wake up and follow commands and end up a Hunt and Hess 2 or 3 in 6 hours. So while he was initially thought of as a poor grade, it's a good poor grade. And then the scan on the right, which is a left middle cerebral artery bifurcation aneurysm rupture, has a huge clot in the sylvian fissure, probably significant elevated ICP. But if one were to treat this aggressively with surgery, large bone flap for the craniotomy, evacuate the sylvian fissure, treat the aneurysm, reduce ICP, while it wouldn't be a great condition, it would be a reasonably good chance that that individual could survive. So that's sort of a medium of the poor grade. The scan on the left is truly poor. So this is a basilar bifurcation aneurysm rupture where the jet of blood has driven up into the midbrain and torn tissues asunder and caused coma. And that is a truly poor grade, and that there is very little chance of recovery given the tissue destruction associated with that. So even in the poor grade, you can sort out people who you have better opportunities for treatment with aggressive therapies. In the neurocritical care arena then, once people get to the intensive care unit, there are a host of issues that can happen that are fairly typical and in some cases rather unique to subarachnoid hemorrhage. Neurogenic pulmonary edema being relatively uncommon in most things, but is part of subarachnoid hemorrhage. It goes along with the cardiac sequelae that we're going to talk more of. Aspiration pneumonia, DVT, etc. occurs everywhere, and hyponatremia has some unique issues in subarachnoid hemorrhage as well, and we'll get to that in a moment. The cardiac sequelae of subarachnoid hemorrhage are a very interesting piece. So cerebral T waves have been described for a long time about diffuse T wave inversions, symmetric inversions across the precordium, but it's become clear as well that there are a host of other problems that occur with subarachnoid hemorrhage. It can lead to dysrhythmias all the way from sinus arrest to ventricular arrhythmias. I think of it as one of the few neurologic causes of sudden death. Fall over dead from a neurologic cause can be with subarachnoid hemorrhage. It can cause frank sinus arrest. One of the reasons that it does that is that with the subarachnoid hemorrhage, we talked about the huge ICP spike that occurs at the time of bleeding. That ICP spike is associated with a huge outpouring of catecholamines triggered out of the sympathetic storm that comes out of brainstem and out the innervation to heart and lung. So that huge catecholamine surge is responsible for a lot of the cardiac and pulmonary difficulties. In the heart, you get this catecholamine storm, and it leads in many cases to a diffuse subendocardial ischemic injury, in part because of the stimulated super contraction and contraction band necrosis in the myocardial cells. You can find this with then presenting in the emergency room with frank hypotension, the stunned myocardium. Ejection fractions can be in the neighborhood of 10 or 15%, and people need pressor resuscitation in the ED. It's, in that setting, tends to involve the base of the heart in a symmetric diffuse fashion, relatively sparing the apex. If you look at that and say, where do the sympathetic terminals end in the heart? The innervation density of those is greatest in the base compared to the apex, and so the degree of this injury really fits well with the maps of the catecholamine innervation in the heart. The troponin leaks can be huge associated with that and are present acutely. And that, I would say, is the typical catecholamine injury in the heart. There is a less common version that really is the inverse of that. So it takes a day or two to show up and ends up affecting the apex far more than the base. So when the base contracts, the apex dilates. And that's been described by the Japanese as taketsubo, or crab pot heart, and really affects the apex much more than base. It too has a troponin spill, although in my view it tends to be less quantitatively than in the earlier version of this I described. And It probably has a neurologic mechanism, but I don't understand it based on the innervation patterns of the heart. And Takotsubo's you can see in acute MI or occasionally in acute ischemic stroke and other things. There is a tendency to lump all of it as Takotsubo heart, and me being a purist of phenomena would say that they actually are different, and Takotsubo should be reserved only for that syndrome where it affects apex and spares base. In a similar fashion, the pulmonary vasculature is innervated as well, and that catecholamine surge goes out that vasculature and leads to disruption of permeability in the lung, and so that is the mechanism for a lot of the neurogenic pulmonary edema. In these settings, there is a lot of pulmonary edema, and it's probably a mixed bag of both traditional cardiac pulmonary edema because of the reduced ejection fraction and hypocontractility, as well as the increased permeability in the pulmonary vasculature. So it's probably not pure, but the pulmonary edema can be an issue that requires significant management effort as well. The hyponatremia in subarachnoid hemorrhage also is a fascinating piece of this, and the sodiums can begin to drop at about somewhere in the first few days, day 3, 4, and may continue for 10 days or so and usually recovers. This has been described as a cerebral salt wasting syndrome, where there's actually increases in atrial natriuretic factor, and part of that is a brain-derived ANF. It will lead to hypovolemia, so I think that it is truly a salt-wasting syndrome. Now, having said that, there probably is also some component of inappropriate ADH effect as well because of the effects of the catecholamine surge and the innervation of the vessels in the kidney. There probably is some disruption of ADH function as well, but there clearly is a component of the natriuretic factor here with cerebral salt wasting. The most important thing, rather than trying to distinguish which of these it is, SIADH or cerebral salt wasting, is that in this setting, following subarachnoid hemorrhage, treatment always involves sodium replacement. So you have to overwhelm the salt loss with sodium replacement. Fluid restriction in this setting is never a good idea, even if you are convinced that this one happens to be more SIADH than cerebral salt wasting. The reasons for that is that there is intravascular volume loss in subarachnoid hemorrhage that occurs, and if you choose to fluid restrict, you're going to make that a whole lot worse. And when you get to the point of vasospasm, which we'll talk about in a bit, you do not want to be intravascularly volume depleted. There is good data to suggest that outcomes are worse. We did that 20 years ago and know that's not a good idea. So we should never do fluid restriction, even if I concede that some of this sodium may be simply an inappropriate ADH effect. There is, fortunately, a spontaneous return of sodium homeostasis over several weeks. So there is an end to this sodium replacement need, although it may not seem that way in the first few days. There are major problems in subarachnoid hemorrhage to plan for. And part of my initial statement that everybody needs a strategy is you think about which of these, how you're going to deal with the big three are aneurysm, re-rupture, hydrocephalus, and vasospasm. So aneurysm re-rupture is a bad thing and tends to be associated with at least a doubling of morbidity and mortality. And it occurs highest risk in the first 24 hours after aneurysm rupture, probably 1 to 2% in the first 24 hours. It tails off a little bit. It's probably a cumulative risk of around 20% over the first 2 weeks if you are unable to treat the aneurysm. Worst in the first day, tails off, but it still adds up to a huge piece. So that the best strategies for this really would be early aneurysm treatment, and this is, I think, the answer in current days is to fix the aneurysm. And I am less concerned at the moment about rebleeding as to how one chooses to fix it, either surgical clipping or coiling of it. That they have different reasons to choose one or the other, but as a strategy to reduce early rebleeding, I'll take either one. And it's the best to try to get these things treated in the first 24 hours for sure, in as many cases as you can. The clinical trials of comparing clipping and coiling in acute subarachnoid hemorrhage, there's one that has been published that suggests that outcome is a little bit better in coiling of these aneurysms, and I think that that has become a much more common and popular approach for those aneurysms that are anatomically configured in a way that coiling them is favorable. When I was beginning this business years ago, in order to reduce rebleeding, people used to use antifibrinolytics like aminocaproic acid. It was associated with reduced bleeding, but worse vasospasm, and really fell out of favor. More recently, people have started using it in that 24 to 48 hour window that it takes to get the aneurysm treated, and there may be some benefit for using it in the first few hours, but certainly not for the prolonged course. Hydrocephalus conceptually is pretty straightforward and simple. It is fairly common at presentation. I said maybe a third of patients will have symptomatic vasospasm at presentation. It can develop in a more subacute fashion over the days. So if at day 4 or 5 your patient is getting sleepier, one consideration would be the development of hydrocephalus. And then there is a more chronic phase in the months after that appears much like normal pressure hydrocephalus. In part, it is normal pressure hydrocephalus, and may be very responsive to shunting. The one thing I will tell you about the hydrocephalus in this setting is that when you put the ventriculostomy in and drain at particular heights to deal with pressures, you may find that in order to actually treat the hydrocephalus, you have to drain the ventricles at fairly low pressures of 5 millimeters, 0, because the compliance, the stretchiness of the brain. So the size of the ventricles are related to the pressure by how stretchy or compliant the brain is. And subarachnoid hemorrhage tends to increase compliance so that the ventricles get big at fairly low pressures. And so you could put in the ventriculostomy, set it at 15, and say, well, there's no fluid draining, this can't be hydrocephalus, would be a failure in concept here, because it isn't the pressure, it's the size of the ventricles. And so you need to lower the ventriculostomy until it drains and allows the ventricles to decompress if you're going to adequately treat the hydrocephalus. And particularly the older folks with subarachnoid hemorrhage have very compliant brains, and you may be setting them at 0 just to get decompression. The biggest of those three, the hardest to deal with, after rebleeding hydrocephalus, we move to vasospasm, is one of my favorite problems because it is still, after all these years, a biggest piece of mystery and difficulty with management. So vasospasm refers to that phenomenon of narrowing of arterial lumens in portions of vessels around the base of the brain, termed vasospasm by the angiographic appearance, but not like vasospasm in other scenarios that you know. It has a very predictable time course in that the clinical phenomena almost never appear before day 4. It gets worse and worse and worse, peaks in the day 10 to 14, and then has spontaneous resolution. It's fairly predictable in location in terms of which blood vessels are involved, because it is related to those segments of vessel that are surrounded by clot in the subarachnoid space. That was nicely described by C. Miller Fisher shortly after CT scanning became available. and he developed the Fisher group score to predict risk of vasospasm based on how much subarachnoid blood and how thick it is around the vessels, so that Fisher group 1s have essentially no significant blood in the subarachnoid spaces around the vessels. Group 2 have diffuse blood. Group 3s had big clot around the vessels in the basal segments, and group 4s had all intraventricular blood and no subarachnoid blood. And you could see risk of vasospasm going up 1, 2s, and 3s, and then dropping off in 4. A very nice demonstration of the association of clot around the vessel and the development of vasospasm. Having said that, there's probably some individual variation about age. Probably younger people have more difficulty than older patients. The likely mechanism of this still remains somewhat unclear, although probably hemoglobin breakdown products and oxyhemoglobin specifically are the most likely candidates for the spasmogen, if you will. And this process involves both a tonic smooth muscle contraction. It's a tonic one, though. So if you are doing an arterial blood gas and put a needle in the radial artery, that thing will clamp down so much that you may not have even a pulse. And that is true vasospasm, but it's very short. It's fast, short, and it goes away. This is a much more tonic contraction that is not blocked by calcium antagonists as we know it, and lasts for days. There's also a part of it that's an inflammatory arteropathy, so that there's edema and swelling in the media, and it thickens at the expense of narrowing the lumen, and there's infiltration of white cells as well in that inflammatory piece. So it is a more complex arteropathy than simply vasospasm. And Fisher had described that it really fits with where the blood is. So you can see here there's going to likely be spasm in the basal segments of this. And angiographically, you see this narrowing of vessel really comes right at where the internal carotid enters the skull and pierces dura. As soon as you pass the dural ring, there's marked narrowing of the internal carotid and of the A1s and M1 segments as well. And this is vasospasm. It's can be significant enough, of course, to cause ischemic injury and stroke, and that's the problem with this. What does one have to do to deal with this? The only real medical therapy, the only drug that has an indication for use in vasospasm currently is nimodipine. And there were multiple clinical trials looking at nimodipine to treat vasospasm. And it is probably true that nimodipine at 60 milligrams every 4 hours, started as soon as possible after subarachnoid hemorrhage, is associated with a modest improvement in neurologic outcome related to ischemic or stroke deficits. Exactly how it works, I think, is still unclear. In any of those trials, they were never able to demonstrate that there was actually an angiographic effect, so that the angiograms looked the same, didn't actually prevent the vasospasm per se, but outcome was better. It may be that it is simply the only model in which a neuroprotective agent works. Nimodipine is an L-channel calcium antagonist that has fairly good CNS penetration and may simply be a neuroprotective agent, because remember, this would be the only model I know of in human clinical stroke where you could give the neuroprotective agent prior to the onset of the ischemic symptoms. So you start nimodipine on day 1 or day 2, the vasospasm doesn't occur and develop ischemia till at least day 4 or 5. So this is the only scenario you get to put your neuroprotectant in before the event. Everything else we do in stroke, we're chasing the ischemia 4 hours later, 6 hours later, and we have yet to be terribly successful in that endeavor. But here, this is the only place you can pre-treat, and this may simply be a neuroprotective effect. I am not sure. The standard therapy for subarachnoid hemorrhage that you will read about and will be on your exams are Triple H therapy. That is hemodilution, hypervolemia, and hypertension. I'm here to tell you, you should know all three of those for the boards, but you should only use hypertension for therapy. The hemodilution really is a strategy aimed at playing the rheology or viscosity game. So for most people, the major determinant of viscosity or thickness of the blood is red cells. Yeah, if you have paraproteinemia or something, I'll give you that. But for most people, it's red cells. And decreasing hematocrit improves viscosity, but of course you begin to lose oxygen carrying capacity if you take too many away. And somewhere in the 30s is probably thought to be the optimal place. And that's pretty much where most everybody ends up after a week in my ICU with therapeutic phlebotomy, fluids, etc. It is very uncommon to ever need to think about therapeutic phlebotomy unless you happen to have a primary or secondary polycythemia coming in. If you have a crit of 65 coming in the door, you may make me think about it, but usually there's no need for therapeutic phlebotomy. Hypervolemia has been talked about a lot, and for years people put in Swan-Ganz catheters or pulmonary artery catheters and tried to drive wedge pressures up and cardiac index, thinking that increased preload made increased cardiac output and that would help the brain. And the truth is, I think that too is while conceptually appealing, may well be wrong. It isn't cardiac output that you really are worried about. What you really are concerned about is cerebral perfusion, and perfusion across that vascular circuit is going to be related largely to the driving force, which is the pressure differential, the perfusion pressure, and the resistance in the cerebral vascular circuit. It's fairly simple. It doesn't matter what the cardiac output is. It's not in there. It's just driving force and cerebral vascular resistance will determine cerebral blood flow across that vascular bed. Now, ordinarily, the brain is very good at maintaining perfusion. So in the everyday circumstance, the brain can adjust the resistance in that cerebral vascular circuit through autoregulation and can maintain perfusion over a wide range of blood pressures so that the brain can compete with the kidney, can compete with the gut on any given day pretty well. The problem with this, if you remember what that angiogram looks like, the problem with vasospasm following subarachnoid hemorrhage is that somebody put a resistor in that proximal circuit right at the base of the brain, and you can no longer reduce the resistance in that cerebral vascular circuit in order to compete with everything else. It becomes the highest resistance vascular bed. So you're getting strokes when your kidney and gut and muscle are perfectly happy. So increased cardiac output without increasing pressure just shunts more blood in the lower resistance circuits. All we can do is increase driving force across that. And so induced hypertension becomes the major intervention in this, and we use phenylephrine or norepinephrine as a pressor to increase mean arterial pressure by 20%, by 40% as symptoms begin to develop. The problem with trying to do much hypervolemia is that it is associated with the most of the morbidity in this. I usually say that the only people you can really make hypervolemic are those that you shouldn't. So if you have renal failure, if you have a poor heart, you may be able to expand the intravascular space, and then you're in pulmonary edema and you wish you hadn't gone there. For most people, the more fluid you put in, the more comes out. You really never get hypervolemic in the first place. So I would say forget about that except for the board question of Triple H therapy. We tend to spend most of our time watching for ischemic symptoms related to vasospasm, and that's with frequent neurochecks with our neurocritical care nursing. You may do transcranial Doppler. You may do CT angiography as imaging of this when you become concerned. The goal is to titrate up your mean arterial pressure in your medical management should patients develop symptoms, but if that fails, then it becomes much like an acute stroke syndrome where people develop symptoms. You've done everything you can. Your only other alternative then is to move to an interventional approach with intra-arterial therapy. And so you can go to angiography and either do compliant soft balloon angioplasty of those segments, or intra-arterial calcium antagonists may have some short effect of 12 to 24 hours. So that, remember back to my discussion about cerebral perfusion, if you can't increase the driving force, the next strategy is to try to reduce the resistance in the cerebrovascular bed. And so these intra-arterial therapies are all aimed at reducing resistance by causing vasodilatation, because that's the only other option. And this just is a graphic of over days of developing vasospasm and increased transcranial Doppler frequencies, and then angioplasty, and you can see the restoration of lumen in that vessel. There may be some new hope. We're looking at intravenous sodium nitrite as an arterial dilator, as a nitrous oxide donor. Don't know if this is going to work or not. It works great in primates, but we're really at the phase of trying this in humans at this point in a phase 2 trial at the moment. I've gone through a lot of stuff in a hurry, but I'd love to talk about any of this that you have questions about. Dr. Greenfield.
Well, so thanks very much. That was a great summary of the treatment options, and I think we've all sort of grown up with Triple H therapy and then sort of scratched our head when it doesn't always work. One of the things that I've been concerned about is, you worry that when you're driving the blood pressure up, how high do you go, and is there a trade-off with rebleed rates? Is there a point at which you're going to cause that aneurysm if there is one that's not been treated to reopen and bleed again?
The question of rebleed, I think, is why we put so much emphasis on treating the aneurysm in the first 24 and 48 hours. If it's been clipped or effectively coiled, I tend to forget about rebleeding from that. And if there's a second unruptured aneurysm somewhere, I forget about that too. I think that can be ignored. So the hard part would be if you can't actually treat the aneurysm and you get in that game of treating vasospasm with an untreated aneurysm. And that, I grew up that way in the beginning, where we treated everybody at 14 days. So I've got a lot of experience with that, and I can say most of it isn't happy. If it's been treated, we drive pressures easily, systolics in the 200, 220 range. But it is true that not everybody responds well to pressors, and there are some individuals that just don't respond. And part of it may be those with the bad hearts, although the stunned myocardium tends to recover prior to vasospasm usually, but there are some that just don't respond to pressors, and I think that's the time where you may tumble to an intra-arterial approach to reduce resistance because you can't really increase cerebral perfusion pressure.
Is there any correlation between the extent of subarachnoid hemorrhage or the areas involved and SIADH development? The reason I ask is SIADH a natural triplet therapy gone wrong, and can it be its management be more individualized depending upon the type of subarachnoid hemorrhage?
I think that the answer to that question about the amount of the component of the hyponatremia related to inappropriate ADH versus salt wasting is not known in most of these cases. Clearly, the hyponatremia tends to occur more with the higher grade subarachnoid hemorrhages, and the higher grades are related probably to more volume of subarachnoid hemorrhage, to get to your point. I tend to think that whatever you do, you just need to deal with sodium replacement, because if you look at intravascular volume, it tends to drift down in subarachnoid hemorrhage no matter what you try to do. And it puts you in a bad way when you get to vasospasm if you're hypovolemic. None of the pressors work and you got to give volume. So I tend not to do fluid restriction at any point. Now, if you were going to do voltaptan or something, you could perhaps go that route, but I think fluid restriction would not be good. One of the in terms of as a vasospasm ischemia detection monitor. Mm-hmm. The whole question of monitoring for developing vasospasm or ischemic injury is a challenging one, and there isn't a perfect answer. So that there are people that do a continuous EEG, and Paul Vespa's group probably is the biggest proponent of that, of EEG. Other people do transcranial Doppler. There's nothing that's perfect. I think there may be benefit in either of those, depending on what you're used to using. For Paul, EEG seems to be useful. For me, I like transcranial Doppler, although neither of those are very good. In my heart, I think that for 20 years I've been saying that transcranial oximetry and the near-infrared systems are going to be the answer to my neuromonitoring problem. And it has been slow to develop, although I will say that there are devices that with non-invasive percutaneous near-infrared systems that provide focal cerebral flow information, so that may be a much better approach of looking at changes in blood flow that can be used as a monitoring system. Currently, nothing is perfect.
Are you using, or have you used, or have any experience with ischemic preconditioning to prevent ischemic damage after vasospasm? This is the perfect setting as a neuroprotectant strategy.
I certainly haven't, and I'm not aware of much discussion of that in the literature, although it's a reasonable idea. This, as I say, this is one of those fascinating things where you know what's coming, but you don't always have a way of dealing with it.
Thank you for a very well presented lecture. I have a question about the issue of the compliance of the brain. That's very fascinating. I can't see how the brain gets softer. Is it a vascular problem primarily?
I don't know. There is a difference in compliance in brain with aging, and so we sort of recognize that. But there's something about subarachnoid hemorrhage, and I don't know what that is. I don't know whether it's changed. You would think that if it's just interstitial edema and all those things, that would increase or decrease compliance. So I don't know. I only make a point of that because in my years, I've seen a lot of people who sort of decide that it can't be hydrocephalus because the pressure isn't high, and yet I've also seen if you drain that, people wake up and do better. So that there is a piece of this that is different.
That's a great study for a biomedical engineer.
Within this, there's a lot of that. There are fascinating engineering pieces. There's a startup company in California that has a device that is, they're ex-sonar guys. So they put a little acoustic energy in and record the echoes. And apparently there is a change in that signal associated with vasospasm, also with brain concussion and things as well. But and some are passive. The arterial pulsation that comes up the carotids is not perfectly symmetric in most of us, and so there's a subtle torque because it hits one carotid before the other, and that signal, the passive signal, changes with vasospasm as well. So the engineers are into this.
What do you think about using agents like modafinil and other agents in the subacute setting?
I guess for me, I'm not convinced it helps us much.